A 11-year-old boy sustained a fall while jumping on a trampoline. He has moderate back pain, a L5 radiculopathy, and weakness of the right extensor hallucis longus (EHL). Radiograph and a computerized tomography (CT scan) of the lumbar spine demonstrate a slip vertebral apophysis. The recommended treatment is A. Laminectomy and excision of annulus and vertebral body margin, B. Bed rest, C. Thoracolumbar orthosis, E. Physical therapy, E. Spinal traction. And the answer is A. Laminectomy and excision of annulus and vertebral body margin. Okay? The reason for this answer. And it is an analogous of Salter-Harris type 2 fracture. A portion of the apophysis and annulus slip posteriorly and may impinge on the existing nerve root. These usually do not resolve spontaneously or improve with conservative therapy, and excision is usually indicated. Slip vertebral apophysis or apophyseal ring avulsion, it is very rare. It is an uncommon cause of radicular low back pain in pediatric age group, adolescent, and athlete. This lesion is one of the differential diagnoses of this herniation. It is because the fusion between the ring apophysis and the vertebral body do not occur fully until the skeletal growth, that is at the age of 18 to 25 years old. Fracture of the vertebral ring apophysis is an uncommon but important cause of back pain in adolescents. It usually follows a strenuous physical activity or trauma. The ring apophysis of vertebral bodies appear at the age of 5 years and fuse with the rest of the body at 18 to 20 years, in some cases up to 25 years old. The annulus fibrosus is adhered to the superior and inferior vertebral plateau via the Sharpey's fibers and also to some fibers of the posterior longitudinal ligament. For these reasons, the fractures are commonly seen along the posterior aspect of the end plate in the middle, midline. Rarely, it may be seen on the posterolateral aspect of the superior end plate. This figure depicts A. View of the ossified rings and the start of fusion. B. It shows an anatomical view of the intervertebral disc and the attachment of the Sharpey's fibers. You can see there's a posterior longitudinal ligament there. Herniation of the disc occur through the fractured fragments, and this may prevent healing and reunion of the fragment. Study done by Potas et al. 2002 and Bay et al. 2013, the common affected region are the end plates of L4, L5, and S1 vertebral bodies. High clinical suspicion and investigation are important for planning the treatment and proper surgical approach. CT scan is the modality of choice to diagnose apophyseal fracture. It has the best performance of the demonstration of the size, the shape, and location of the fracture. Excellent demonstration of the relationship between the fracture fragments and the herniated disc is possible with CT scan. This computed tomography CT images shows an axial slices through the apophyseal ring fracture. You can see the arrow. Sagittal slash shows the double injury of the apophyseal ring. It is arrow marked. CT scan further helps to differentiate the calcified or non-calcified fracture from the lumbar disc herniation. The MRI identifies only 22% of the fracture. However, MRI helps to show the herniations or extrusion of the disc and its mass effect on the contained nerve root. There are many classifications that can be used. Among the commonly used are Epstein classification. It's a modified Takata classification based on the morphology of the fracture is used. These fractures were classified using a CT scan by Takata et al. And it divides into 3 types. Type 1. The posterior margin of the vertebra shows small separation. No abnormality is seen in the underlying vertebral body because only minimal bone loss occurs in the fractured fragment. An awkward fragment is seen to lie within the spinal canal. This type occurs frequently in individuals younger than 13 years old. A type 2 is an avulsion fracture involving the posterior margin of the vertebral body along with the overlying cartilage and annulus fibrosus. The fragment has an irregular shape. It is seen in older children and adolescents. Type 3, the fracture fragment is larger than the vertebral rim and leaves a round defect in the adjacent bone. It is seen more frequently in adults. Okay, thank you.